Hey, all you cool cats and kittens. Yes, I have watched Tiger King, and I'm on my second time around because I finally convinced my brother to watch it. So, we are on our very last lecture of the semester. Yay! I don't know how excited you guys are or not, but it'll be nice to have a little bit of a break with how crazy the world has been. We're kind of referencing everything we've learned this semester in with these scenarios, kind of bringing it all together, tying it together. You will just a little bit of housekeeping. You'll see I didn't do a weekly quiz this week. That's because you had both an assignment and there isn't really much on any reading or anything I could test you guys on. So I just thought we would skip the quiz so you could work on your assignment and get ready for the final. So just study up for the final. Make sure to fill in the final review, what you guys want to review, and then also I will try to finish up the final and try to get it posted tomorrow is my hope. So that's all the housekeeping. Let me know if I missed anything or if you guys can't see any of the lectures. Okay. Basically, I'm going to tell you guys 5 stories of scenarios I've been in at work. So that's why it's let me tell you a story. Again, we'll go through 5 different scenarios. These are commonly seen scenarios you guys will go through as respiratory therapists. I thought about picking just random weird stuff, like the guy had a complete left-sided pneumonectomy, and so I had to cut all his tidal volumes in half because he only had one lung. But we're going to go through commonly seen ones so that we can practice that. It's going to be a lot of me talking about the how and the why and responding to certain ways you would respond to the bedside. So I'm just going to be apologizing in advance for you listening to me talk, just as with our other recorded lectures. Okay. Scenario 1, Jacques Strapp is a 55-year-old male. He's 5'9" and 290 pounds. So immediately we start thinking, okay, he's 5'9". We might need his tidal volume, potentially. In this scenario, we would go off of his height and not his weight, because his weight is higher than his ideal or predicted body weight. He has a previous medical history of hypertension, mitral valve stenosis, and opioid dependency. So a few things we're going to be thinking is, okay, he has a sick heart, mitral valve stenosis, and some hypertension. Those are going to add stress to the heart. Opioid dependency. That means he's going to metabolize opiates faster than most people, and he's going to need more for pain. This is pretty common with early extubation, and we will talk about how that comes into being an issue. So Jacques is undergoing a mitral valve replacement. You'll also see it written as an MVR. Orders patient on early extubation protocol once hemodynamically stable. We are transferring the OR call. They're headed to the ICU in about 30 minutes. So let's think, where do we start and what settings would we use? Where we would start is I would get my ventilator. In this patient, I probably would get, since we're doing okay and we're just trying to wean to extubate, I would get what you'll commonly hear called a dry circuit. And this is without the Fisher-Paykel or the Concha heater, and just an HME so that it's faster turnaround of the ventilator, and because the patient's only going to be on for a short period of time. Next, I would get everything else I need. I would get a Ballard suction. I would get whatever your facility uses to secure ET tubes. So I have used anchor fasts my whole career, so I'd grab an anchor fast. And then before your patient comes up, I just set up my suction both to my Ballard and to my oral suction, and also any safety precautions you might do, such as just making sure you have a bag mask just to ward off evil spirits. It's pretty common. Okay, settings. Again, I am a believer that with rapid extubations, you either kind of want to do all or none. So I would set this patient up on assist control. Some places use SIMV. Go by what your facility uses. And then I move to pressure support as soon as the patient is stable. I will go a slightly higher rate and PEEP, and here's why. In the OR, especially when they're doing thoracic surgery, they'll keep the patient slightly acidotic and their lungs slightly hypoinflated so that they have room to work within the chest to work on the heart. So this patient has had their healthy lungs just underinflated for the few hours it takes to do the surgery. So this is why I will do a rate of 20 to overcome that slight acidosis, and I like a slightly higher PEEP, such as 8, so that we can work on re-recruiting our lungs so that they are, I like to call it kind of a tune-up. I call it my tune-up PEEP, so that they have a little bit higher PEEP in order to allow for appropriate alveoli recruitment, and so it's easier to extubate once they're finally awake and ready to extubate. Tidal volume, you can do anywhere from the 6 to 10. I typically like 7 or 8 range per mils per kilogram because these lungs are healthy and we're just trying to open them up, inflate the lungs, and get ready to pull the tube out. Finally, FiO2, since it's not emergent, but I still like to shoot higher, I start at 60% and then wean my patient down to where they want to be on their FiO2. So, continue. So we're going to grab and set our vent and place on standby. This way, on standby instead of just off, some of these newer vents are super nice. The standby is great, but they take a while to start up. So that's why I would put it on standby. So then I can just pop it on my patient and then it will automatically start working. I already calculated our predicted body weight. So 70.7 kilograms or 71 if you guys just want to make life a little easier, your math. Pick your settings. We already discussed settings. What ventilator variations would we pick for a post-op patient? This is where you would either do assist control or SIMV. And then once your patient is awake and responding, you would switch over to pressure support. And I typically will start at a higher, like a 15 or 12 pressure support, and then wean down. And you go pretty aggressively when you're doing a rapid wean to extubate. So I will be like, okay, we're doing good, and I'll stand there and watch their return volumes, make sure that they're doing okay until finally we are ready to extubate. Okay, and then what would you include in your SBT values and extubation assessment? First thing I do is I make sure they are having their own spontaneous respiratory rate, switch to pressure support, bring the pressure support down, and you will want to wean the pressure support down to either a setting of 5/5 or 0/5 and 40% or lower on the FiO2. This is so that you can support this patient on a nasal cannula once they're extubated. You do this SBT on the 5/5 or 0/5 for a minimum of 30 minutes. Then I like to go in and assess their neurostatus. I'll have them at some point in the SBT process give me a thumbs up, lift their head, respond yes or no, something so that we can tell that they're responding appropriately. Next, we'll do our baby deer cheerleader assessment. So while they're just relaxing outside and I'm chilling outside the room or just barely in the room, I'll get their rate, their respiratory rate, their tidal volume, their minute volume, and their RSBI. Those are the very first values I collect from my patient. Next, I go in and I do a vital capacity, which we talked about last lecture, and a NIF. Then after that, I will suction down the tube, back of the throat, make sure we have a cough and a gag, and then I'll deflate the cuff for a leak, check with my team, and see if we are ready to extubate. After that, I will assess my extubation assessment. I listen to their lungs, I listen to their neck, just to make sure we don't have any stridor. And then I'll place them, make sure I suction their mouth really well, and then place them on oxygen. One thing is, you'll hear it called a drop-off tube. It's a feeding tube that they place that the nurse will have to put a wire in. So make sure to ask if you see any type of feeding tube that's more than a big, thick orogastric OG tube, if they need to secure that so that it doesn't come out with your tube. Okay, that's our first scenario. Scenario 2, B O problem, is a 42-year-old female. She is 5'3" and 130 pounds. She has a previous medical history of alcohol. ETOH is alcohol, that's the chemical term for alcohol, and a recent breast augmentation. B is already intubated in the ICU after one of her silicone breast augmentations ruptured and the patient developed septic shock. Again, you can't make this stuff up. This is a patient I've had. Our current settings are assist control, volume control, rate of 20, tidal volume 500, PEEP of 12, and 25% FiO2. Blood pressure is tanking and patient is not oxygenating. So right off the bat, I like to ask, what are a few red flags? What is going on with my patient? Assess your patient. So this patient is septic, and it's not due to a pneumonia or anything with the lungs. So odds are she's going to have blood pressure issues, because that's what happens with shock patients, is they can't maintain their blood pressure. And that makes it so it's difficult to oxygenate, difficult to keep vital organs alive, kidneys take a hit. It's a whole systemic process. Your brain, your eyes, everything. So a few things I'd look at. Volume control, a rate of 20. I would call that appropriate. I think that I would call that 500 tidal volume way too big for this patient. Normally a PEEP of 12 is fine. I wouldn't be too worried about it, except that we are in septic shock and her lungs were not sick. She is septic. Her issue is overwhelming infection. I'd bring my PEEP down and my FiO2 up in order to make sure we have appropriate venous return for blood pressure and that our FiO2 is high enough to support oxygenation. Because at this point, it's more the fluid in the pipes of the systemic vasculature and all that over the lungs of and the pressure gradients in the body that is making it so we're not oxygenating, not PEEP, and not alveolar derecruitment. So again, what would be special considerations for this septic patient? If I have a patient that is overwhelming sepsis, I'm sorry guys, I am okay with slightly higher FiO2s, because again, it's not so much a pressure gradient issue from across the lungs as much as it is from the vasculature, from different vital organs that are taking a hit, and low blood pressure. How could we help with oxygenation and blood pressure? Again, I would bring that PEEP down. You could even go to 10 or 8 and then bring my FiO2 up. At this point, we need chemical more than therapy. What other changes would you make? I would bring that tidal volume down and adjust my respiratory rate to be appropriate with what my ABG says. And how may your ABG and chest X-ray respond to both the treatment and pathology? So ABG, we might have a metabolic component with B. B is going to have a slightly higher lactate, which is going to affect our bicarb. So you're going to have to maybe do some adjustments on the vent that might make you feel a little more uncomfortable, whether it be a slightly higher CO2 or a slightly lower CO2, in order to regulate your pH, because the bicarb will be out of whack. If it's very out of whack, they need to give bicarb, they need to give fluids, other antibiotics, other methods in order to help your patient. But just for acute sudden changes, it's pretty common to have to make changes on your ventilator in order to regulate pH. Your chest x-ray, your lungs probably won't look terrible. But the fact that this is happening on the thoracic cavity might affect coughing after she gets extubated. So since she probably had both the breast augmentation surgery, she doesn't want to cough, and then they probably went in and cleaned her out and fixed it. That's going to make her not want to cough. Once she's extubated, you have to work on getting her to cough. It will be the biggest thing. And then that was her predicted body weight. So clearly 500 was around 9 or 10. We would still want to shoot for a slightly lower tidal volume, around 6, maybe even 7 mils per kilogram. Mrs. B. Again, you can't make this stuff up. I remember getting this patient being like, what? Her boob exploded? I almost made that the secret word, but we won't make that be the secret word. Okay, off to our next one. Scenario 3. Mike Roch is a 75-year-old male. I hope you guys are appreciating these names. I had a lot of fun picking them out. Is a 75-year-old male. He is 6'1" and 163 pounds. He has a previous medical history of a 50-pack year history of smoking, COPD, and emphysema, which is poorly controlled. He has a DNI order signed previous to admission, and a recent URI, or upper respiratory infection. So let's break this down for a minute. I'm assuming this guy just does not care at all. If he's just going to keep smoking, he doesn't care. He has poorly controlled emphysema. He doesn't want to take the time to work on getting his meds or fill out the paperwork to get financial assistance to pay for his meds. But at the same time, he has a DNI because he's like, I'm 75 and made it this long, but I don't want to be on a vent, which honestly I think is fair. Presently, Mike presents to the ED with extreme shortness of breath. One assessment you can make for dyspnea, an objective assessment, is how they're talking. So if they're doing one-word sentences, this is where they're going, I can't breathe, and they have to take a deep breath between each word. Bilateral wheezing and a low SpO2 on room air. That's all you know until you walk into the room. You don't know if we're in the 70s or the 60s, the 80s, or low 90s. Okay, what do we want to do for this patient? So remember, a few of the factors are we have an obstructive disorder, we have a DNI order, and we are having a COPD exacerbation due to an upper respiratory infection. If it were me, I would grab my BiPAP and place this patient on BiPAP as fast as possible. These patients respond very well to BiPAP. That way you can get that pressure, support ventilation, and oxygenation all at once while also trying to avoid an intubation. Some other treatments that would be appropriate would be to nebulize a bronchodilator for this patient. So I would give Duoneb and albuterol, and maybe just throw a couple in there. Different hospitals have different policies. You can give 2 or continuous, 2 Duonebs or continuous, and then an albuterol. You'll have to, when you guys start working, you'll have to see your policies. My honest opinion is it's albuterol. If we need to give a little bit more, let's give a little bit more. Just make sure that when you nebulize, if you do a spring T adapter, to put it after the whisper valve so that the patient gets all of the medication and it doesn't just go out into the room. Another reason I like to give aerosolized medication through BiPAP after the whisper valve is so that it kind of goes a little bit deeper into, it makes it easier for that medication to go deeper into the lungs because of that positive pressure. So it becomes a little more effective. Some other treatment that would be appropriate would be an IV steroid. Normally, on a well-controlled patient, inhaled corticosteroids for home are appropriate, but it takes up to 2 weeks to see any benefit from it. Whereas an IV steroid, you can start seeing improvement within 6 hours for a systemic steroid. That's why we prefer to give IV steroids. Others would be potentially fluids, Tylenol if they have a fever from their upper respiratory infection or whatever their sickness is. And then maybe even something for anxiety to just let them sleep and let the BiPAP do its thing. Okay, so we already talked about this a little bit, but what modality would be most appropriate? And I would say BiPAP. Okay, what changes would be made to fix the following ABG? So we have a pH of 729, a CO2 of 82, a PO2 of 66, and a bicarb of 30. So this patient obviously lives with a little bit higher CO2 because our bicarb is starting to creep up a little bit. But at this time, because we're having an exacerbation, we're going to want to increase our IPAP in order to improve ventilation so that we change that delta P, that difference in pressure between the IPAP and the EPAP. A PO2 of 66 per Lindsay Jones, that's not appropriate. You'd want to increase both the FiO2 and the EPAP, but also change the IPAP greater than the EPAP so that we improve both the delta P and oxygenation. If it were me working, I would honestly be pretty happy with a 66 PO2 on a COPD exacerbation here in the state of Utah, but that's not Lindsay Jones appropriate. So that's what I would change is I would first fix ventilation and then oxygenation and then perfusion. Just keep it simple. I'm all about the KISS principle of keep it simple. So we fix our ventilation, increase our IPAP, increase oxygenation, either increase FiO2 or EPAP, while also maintaining an appropriate delta P. And then perfusion, just monitor his blood pressure and heart rate. Would there be medication that you'd want to administer? Yes, we already discussed that. We'd want to administer Duoneb, which is both albuterol and Atrovent, and albuterol, while also the nurse would give IV steroids, fluids, and potentially something to help the patient calm down, because it does make you stressed when you can't breathe, and I feel that's a valid thing to get anxious about. If you can't breathe, I would be anxious too. I'd want something to calm down. Okay. What would you assess in your physical assessment of this patient? First thing you do, you walk in, you assess your patient. Your patient probably is using external muscles to breathe. They might have a little bit of a gray tone to them. They will have what I like to call the flop sweats, where they're just sweaty because they're stressed and can't breathe and they're working hard. It's like they're running a race. When you listen, you might either hear absolutely nothing or a wheeze. If I don't hear anything and then I start hearing a wheeze, that means my airways are starting to open up after a treatment and after BiPAP therapy, and that is a sign of improvement. Once stabilized, what questions about their home would you ask? This is kind of more of if you're working as a case manager situation, would be, are you able to afford medications? What's keeping you from taking your medications when you're home? Is there any way we could help you? get the medications you need. Also, just educating about why it is important to take their medications and work through management and how prevention is better than treatment. So good job. You saved my crotch. Okay, scenario 4, all of her clothes off. I'm gonna have to thank Bart Simpson for all these. Is a 48-year-old male. He's 5'10" and her 92 pounds. So his previous medical history, this is the type of patient I've taken care of quite a few times. Previously healthy, absolutely no medical history, maybe like the occasional acute like sinus infection or whatever that everybody sees the doctor for. He came down with influenza, which then led to pneumonia, which led to severe ARDS. Well, because of that, he had to be placed on VV ECMO. For those of you that will end up working in ECMO units, typically they place VV, which is the venous, where for lung issues, and VA for heart issues, venous arterial. Okay, so he has since been decannulated from ECMO, and because he is so weak and his lungs have been so sick from his ARDS, from his flu, and he was needing mechanical ventilation so long they placed a trach, and we are to the point where we can begin weaning him. He's doing really good. This guy was very strong and healthy before, so he's ready to get going and get back home. So we want you to design a weaning plan for Oliver to come off the ventilator and possibly decannulate from his trach. So where do we even begin? Okay. How would a plan for Oliver vary different from other patients? So for Oliver, he's still pretty weak. He's been through the ringer. So we're not going to push him as hard as I would a post-op or a patient that's just been intubated for a couple days. We're going to have a little more of a gentle hand and go off of how he's responding. So some possible weaning methods. If he's on full on assist control, I would go to an SIMV. This is when I personally like SIMV the most, is long-term weaning methods. After that, a pressure support, and then TP's trials, which is you can either get a high-flow nasal cannula set up and hook it up to the suction. Just make sure you have an exit port, so unplug both ends of the suction, or a trach collar. You can also do an HLVN so that they get both heat, humidity, and oxygen all while working on breathing on their own without any further support. You can also do this on a 5/5 or 0/5. And a lot of times, the first couple times we try weaning methods, we will rest the patient on the ventilator at night. And this is something very, very common with these types of patients, where they'll be on a T-piece on their trach all day long, and then we don't want them to poop out. We want them to work really hard and get the rest at night. So I'll put them on the ventilator on whatever settings this patient needs, such as most of the time I put them on 8/8 and just give them a little bit of PEEP to pop on their lungs, some pressure support so they can sleep while still breathing on their own and being comfortable. And they can just kind of work on doing their own thing while sleeping. And then in the day, I'll talk to them all about this. I tell them all about this. In fact, I have a patient I've been working a lot with lately that I talked to her. I'm like, yeah, we're going to rest on this tonight so that you can work hard and get up and walk with therapy and everything tomorrow. Does that sound good? And she's like, yeah, let's do this. Get some rest so I can work on getting better. Should the patient be heavily sedated? And that is no. You want to be able to interact with this patient, talk them through it. Obviously, pain management is important, but you don't want them just snowed. You want them alert and working with the team. It helps with ICU delirium, and nobody wants to just be sedated and not there present, especially when they're actively weaning. What other team members may now become involved in patient care? So it's you and the nurse always and forever. But physical therapy and occupational therapy and rehab services might be getting involved here. ENT might also be getting involved, where they will decrease the size of the trach once your patient is off the ventilator for so long. Like, let's say you have an 8-0 trach, we might go down to a 6-0 cuff trach. Then they might do a 6-0 trach that's fenestrated with the holes on the top. Then they might do a cuffless until you can cap the trach so that the patient is breathing completely on their own. And then you can decannulate. And then if you are the one to actually decannulate or take the trach out per doctor's orders, you just put a breathable gauze over top that stoma, and it actually heals really, really fast. It might leave a little bit of a scar, but it's not just going to be an open stoma. It heals fast, kind of like your gums or your fingernails. It's that kind of tissue. So you don't have to worry about it taking forever to heal. They normally close up pretty fast. You guys hear me? Ooh. Okay, you guys can still hear me. Okay. Scenario 5, Amanda Hug and Kiss is a 30-year-old female who is 5'5" and 353 pounds. She has a previous medical history of social vaping and increased BMI. This patient tested positive for COVID-19 and underwent RSI, which was rapid sequence intubation for respiratory failure and suspected ARDS. Once you are in proper PPE and safe, because there are no heroes in a pandemic, how do you proceed? So what they're finding is these COVID patients end up with a raging pneumonia that turns into ARDS, and that's why they have a cough, and it's because of all the consolidation in the lungs, and that's what leads to the ARDS. So, let me just, sorry guys, typo, boop. So while we're still learning about this virus and things are constantly changing, I'm sure by the time I post this, there'll be new guidelines and everything. At the moment, it's behaving very much like ARDS. So even though we have an increased BMI, we have a predicted body weight of about 57 kilograms. What specific strategies need to be addressed in ventilator management? So we want high PEEP. We talked about the physiology in previous lectures. We want a very high PEEP so that these lungs that are damaged and have altered surfactant don't have further damage, and we increase oxygenation, and this is also pneumonia. High rate, so that we have an appropriate amount of ventilation to ventilate, and then lower tidal volume, so that we have lung protective strategies. And then you typically would probably have a higher FiO2. Other things that might end up happening are proning the patient, where you put the patient on their belly. And what's physiologically happening here is basically you're just helping equal out the lungs. So when you're laying on your back, most of your blood flow will go to the back because of gravity, and most of the air in your lungs will kind of go to the superior part of the lungs because, again, of gravity. Once we flip the patient, we allow the blood flow to return to those recruited alveoli, while also allowing blood flow to go to the recruited alveoli, and then those alveoli that were maybe not as recruited to increase recruitment in the hopes of helping oxygenation. That's why proning helps. And also, I don't know about you guys, but I'm a tummy sleeper, and I would just feel better on my tummy if I wasn't feeling well. Would this be a fast or slow weaning process? This would be very slow. You definitely go off of the patient and make little steps as tolerated. You wouldn't just all or nothing. You would work on a decreasing rate so that they can start breathing on their own, slowly bring down the PEEP as their oxygenation tolerates. What else would be indicated in treatment? You might end up sedating or paralyzing. You heavily sedate this patient. You might even paralyze because even movement can increase oxygen consumption in the body. And then how do we manage ABG in special situations of the ventilator? You would potentially have a slightly higher CO2, so high 40s, low 50s. Oxygenate the best you can. Sometimes you just have to happy dance about the fact that you got a PO2 over 60 and you're like, we're not dead. This is fabulous. And then specialty situations of the ventilator. I would definitely put a heated circuit on with a humidity. And then VC plus would be totally appropriate because you would want, again, the higher mean airway pressures but the lower peak pressures. So I would enjoy VC plus for these situations. You might also end up doing an advanced mode that we didn't talk about, that I will talk about in adult critical care, called APRV or bilevel. Bilevel's the manufacturer, but APRV. And then wear your PPE no matter what. We do not want you to get sick. We want you to stay well. There are no emergencies and no heroes in pandemics. Remember this. So take all the precautions you need. Okay, and we are discharged. Sorry for all the talking. Again, you guys are doing great. I miss you. I'm here if you need me, and so is Artie. My niece Boston was tickled pink that Artie wore a crown and she was a princess dog. The secret word of the week is princess dog. If you guys have anything else you would like to add, just write it in your written response. I will get the final up, and then we're gonna be done. Oh my goodness, I can't believe it. Okay, you're all great. Bye.